it on. So the case is because he's a young man, he's 26 years old. He has some symptoms that are not related at all. He says that about a year ago he suffered vertigo, but he went to the ENT and he said it's not vertigo. He sent him to neurology, then it's nothing neurological. And then about a month ago he suffers this again, so they send him to the cardiologist. The cardiologist interprets it as a presyncope, and there are no cardiovascular risk factors, no coronary previous cases, and verbally he told me that he had an EKG that was normal, and that's why the doctor wanted to ask him for this exam. So we conducted this first study, and I don't know what you think about this. Is it normal? Is it abnormal? And this person about 2 weeks ago had a cholecystectomy, and he couldn't do exercise. On the day of the test, he drank his Colombian coffee, and we had to use the butamin. Should I tell you about the results of the stress test? Well, the butamin was positive. There was a reduction in the segment. He doesn't have pain. He totally denies that he has any pain. So, Dr. Vitola or anybody in the audience, can you tell us what you think about this? Just a small comment. First, it would be good to look at the basal EKG because the EKG has a predictive negative value that is very high. Maybe not for identification, but I would like to look at the electrical test because oftentimes it's confused with the SCT. So depending on the characteristic of the SCT, we can determine if it's a positive result from the electrical aspect that we have to consider. Well, I don't remember the data from this morning. It was sinusal rhythm and disorder of inferior repolarization. And I knew that you were going to ask for this, but this morning at 7 in the morning, I was not available and I couldn't bring the stress test. I want to make a suggestion. Let's discuss about this because we have doctors from different countries here. What do you think about this case? And what additional information would you need? Let's just open it up for discussion. Questions about the case, about the patient? It is if it's a patient that suffers presyncope before perfusion, I would implement a halter to see if there's a type of blocking that will give me more information from the presyncope than perfusion. So this is a young patient with a presyncope. One of the often things that we use are coronary abnormalities. So we have to consider this, and a tomography would help us a lot, especially because with stress we can see some changes that could be useful. Somebody asked, the butamin was maximum, it was 85%. They used atropine 1 milligram to get to this frequency. No family cases before. One thing that we see is that sometimes that we work with imaging and we have to do this. We have to take a step back because sometimes it's a trap for us. We have to put ourselves in the position of the doctor. For example, we have a young man, 26 years old, who suffers something like vertigo or dizziness. There's an episode and it seems pre-syncope. But I'm actually concerned about this patient. I'm concerned. When we look at the reasons of death, there is a very evident difference of reasons after 30 years old and before 30 years old. After 30 years old, if it's a sudden death and coronary disease, but below 30 years old, we have to think that it's a congenital disease. As our colleague said, coronary abnormalities. But there's another important thing that oftentimes causes ventricular arrhythmias, and it causes feelings of dizziness and pre-syncope, which is hypertrophic cardiomyopathy. I have conducted diagnosis of hypertrophic cardiomyopathy in patients in the nuclear laboratory based on the EKG in rest and correlating it with the image and looking for hot spots in the heart in the apex. So, and patients who had an EKG that was normal, because in high volume of things, many times the acoustic window is not very good. So the echocardiogram, EKG, clinical perspective, I think that this was fundamental for congenital coronary diseases or a muscle bridge. When I saw this study on Tuesday, I was very much concerned because I saw a mild reduction in the anterior wall, more anteroseptal basal, and also a bit basal mesial in the antilateral wall. And Victor was in the other wall where we could look at this, and I said, I think that this patient moved because it seemed to be diagonal. But Victor looked at it and he said, no, there's no movement at all. So I was a bit disappointed. So I saw this, and I want to put this to discussion to see if there was an improvement between this mild reduction in rest in both areas. So I was concerned about this because he's a patient with a clinical chart that is completely atypical. He's young, but a positive test electrically speaking, but just things didn't match for me. So I will continue to show you the other images. This is just for you to see the histogram so that you can see that we don't have any artifact there. And the movement. If you want me to stop at a slide, please tell me. This one is the movement slide. Ejection fraction in rest, 61%. Volume of end of diastole, 110. Systole, 42. And post-stress, 57%. It increases a little bit the volume of end of diastole, 114, and systole, 49. So it's not significant. Are there any comments? This is the problem with the trap. Because I remember that yesterday we were talking about the Bayes theory when there's a probability. And what is the doctor looking for with this test? I wouldn't do this to conduct this test. I would conduct another test. So we are trying to discuss a test that has a positive predictive value, that it's 100%, and a young person who has a very, very mild thing with a high probability of being an artifact. The main problem here is that if we don't discuss this case with the doctor and we report this as an ischemia, the next step would be to have another test that is not the best test for the patient, which would be catheterization. So we think that we have to stand in the feet of the doctor, talk to the doctor, and discuss about the diagnostic hypotheses. What are we talking about here? We are talking about an abnormal coronary. This is not a test of the abnormal coronary. CT is better. So we're working with the hypothesis of hypertrophic cardiopathy. Maybe we could consider MRI, but if we do the TAC, the CT test, maybe we would have both informations, because CT tests are also good for for these cases. And even better for the intramyocardial bridge, which would be another congenital case. So I would go back to talk to the doctor, and we're going to say we're going to do a CT test in this patient. Don't add hemodynamics, please, because we're going to lose the diagnosis. I could not talk to the clinicist, no. It's an external person, but we are about to do it. We're trying to locate that person. Just a comment about the images, because Joao talked about our probability of the technical defect or the artifact. Can we go back to the previous one? Yes, because there are some specific things here. We can see that this is a young patient. How many doubtful sectors do we have here? You didn't mention anteroseptal here. Basal. Basal anterior, basal inferior. There is a weird thing here. So we are looking at several territories with alterations of the uptake. So it's not probable for this to be a coronary disease. This means that we cannot think about ischemia in several territories in this patient. The other thing is that the volumes are normal, the ejection fraction is normal, and evidently, if the quality control of the study is good, we still cannot disregard basal attenuation more than stress, because if we have a hyper uptake in the basal segments of several territories, maybe it's an artifact with basal attenuation. The patient has 175 and 79. He weighs 79 kilos. And these are the systolic thickening maps. To the left, in stress, and to the right we have in rest. Diastole, systole, diastole, and systole. I wanted to ask a question. The patient had a cholecystectomy in, is it 6 days before? 2 weeks before. Okay, because sometimes there are also arrhythmias in which if we conduct this process in the patients. And the thing is that in a patient of this age, we would be good to have a good algometry in these conditions. I think that this would be fundamental as well. So in these thickening maps, I see this thickening in the anteroseptal region. It's a bit less, and it's a bit insinuated in rest, but it's much more evident here. Polar maps. Dr. Gomez, with the clinical information that we have available, do you think that the study is indicated?
Personally, I believe that mistakes start on how I want to investigate the symptoms. So maybe I perform studies that are not necessary, and I'm going to beat around the bush. Maybe there is no coronary disease. We need to go back. I really agree. We need to ask the patient. Out of the test, we can get more things. What happens with blood pressure at the end of the test? Show us what happened. There's a systolic dysfunction. There are tests that help, and when clinicians look at this, we see that this is ischemia, especially in the maximum exercise peak. Do you remember the ischemic cascade? The ultimate manifestation of that is pain. And for each painful ischemic cascade, there are 4 that are painless. And here we use the clinic to correlate at the point where I am, because when I have ST alterations, we have alterations in contractility because the ischemic cascade occurred before and it persists. But I'm talking about specifically about the exam, the test. Even if it's the wrong test, then it's the normal process to investigate some nausea or presyncope, because we don't know what's happening with the vascular mass. This is the number 1 in the ischemic cascade. Dyspnea appears before angina or ST changes. There is no deterioration in functional class. Yes, I'm sorry, but I didn't get that information. I would have wanted to show it to you, but I was unable to get it. From the clinical point of view, we might think about cholecystitis. Was it laparoscopy, 3 days, how many days in the hospitalization? There may be some secondary causes, not the heart itself, but for these alterations, because a microthrombosis prior to the surgery or a septic state, after the patient's discharge. No, I talked to the patient and he said, I was unable to exercise because I had surgery 2 weeks ago. So dipyridamole was not used because he had drunk coffee. No complications whatsoever, though. He's a young man. I believe that the first thing we worry about is that the symptoms were not enough to request a myocardial perfusion. But then we start to just go around everywhere. But the thing is, what am I going to do? How am I going to read this? And for quality control, there were no arrhythmias, nothing of the sort. And that's where my case ends. So, I've shown this to several colleagues, and we're 50-50 on ischemia or not. No. That's why I wanted to show it to Dr. Vitola, and that's why he brought it for us to discuss. I would like to add a little thing as a comment. If I have a patient with ventricular arrhythmia, dobutamine is going to unleash it. The probability of arrhythmia, whether ischemic or other, with 2.5 micrograms, we see tachycardia in the unit. How do we stress their heart? And this didn't even happen. Okay, thank you so much. So, let's vote so that I can read the test. Should I read ischemia? No. Okay. There's consensus. Okay, accepted. Thank you so much.